to the conference. Let me leave and come back. Hello, can you hear me?
Yes, can you hear me?
Yes, I can. Good evening to all. I think we're ready to start with today's very promising meeting. Welcome to all. Good evening, Basim.
Hi, good evening.
So I think we're going to kick off immediately with the first talk is from Dr. Sham Osman from Durban in South Africa. and he's going to discuss how to tackle a large rotator cuff tear. So Sham, I think you can share your screen and take over.
All right, can we see that, Leon? Can you see my screen?
Yes.
All right. Well, good evening, everybody, and greetings from Durban in South Africa. Thank you once again to the Egyptian Shoulder Society and the South African Shoulder and Elbow Surgeons for inviting me to give you this talk on my approach on how to tackle large rotator cuff tears. So what is a large rotator cuff tear? If you look at, are you receiving me, Leon?
Yes, we've seen it well, Sham. Please continue.
Thank you. All right, so large tears are between 3 to 5 centimeters and massive tears greater than 5 centimeters. If you look at the supraspinatus footprint, you find that the maximum diameter is 25 millimeters, which is definitely less than 3 centimeters. And therefore, any tear of the supraspinatus will involve partial tears of the tendons neighboring it. So we're going to concentrate on large to massive cuff tears. Massive cuff tears are tears that are greater than 5 centimeters in its longest diameter. And they usually involve more than 2 or more tendons. And the incidence of these tears are quite high at 40%. So we need to recognize these tears in our practice. Why do we need to repair rotator cuff tears? We know that chronic tears would lead to fatty infiltration, and this has been classified by Gutalia, and grade 3 and above means a bad prognosis. Fatty infiltration starts at 6 months, and the mean time to severe change would be 3 to 5 years. So you therefore only have a short window period to try and achieve success. With chronic tears, you also find muscle wasting, muscle atrophy, and shortening, as well as tendon retraction and tendon loss. And this is due to degenerative tendons, and this compounded muscle atrophy leads to a retracted tear, which might become eventually irreparable. So the degree of retraction is important to understand. Stage 3 is when it retracts to the level of the articular surface of the glenoid. And this is a combination of adhesions, muscle shortening, and tendon loss. Chronic tears would lead to subsequent reduced acromial distance due to unchecked deltoid contractility. And this leads to cuff tear arthropathy with degeneration on the long term. So when would you want to repair these? Chronicity of tears, the longer the tear, the longer duration leads to poorer healing outcomes. Fatty infiltration can be overestimated because of inter and intra-observer reliability, and maybe due to overestimation due to muscle retraction. And this may improve after repair of the tendon. This is shown to improve in 86% of cases in big studies. And the other problem is pseudoparalysis. This pseudoparalysis seen in significant improvement after repair of the rotator cuff. And however, chronic pseudoparalysis more than 6 months may not recover, and therefore you need to get in early. Most irreparable tears can be massive, but not all massive tears are irreparable. So this is another concept to understand. What would be your indications for surgery? I would consider a young, active patient who requires strength and mobility as an indication for rotator cuff repair, or in older patients presenting with acute and chronic symptoms. And their good prognostic signs would be pseudoparalysis less than 6 months, a centered humeral head, less than 3 fatty infiltration, and less than stage 3 retraction. So how do we fix these tendons? We apply principles of rotator cuff repair to these, but however, they might differ slightly. We need to create a healing environment. We need to identify the tear pattern, and we need to mobilize the cuff to get a tension-free repair. We also want to get a maximum footprint coverage, uniform compression on the footprint, leading to a strong mechanical fixation from ab initio. And we also want to reduce to minimize the anchor diameter to allow more footprint available for repair. We also may want to consider microfracture. We know that healing comes from the bone marrow stem cells, and these will be combined in large massive tears. Bleeding comes from the bone and allows for healing. What about anchors? Anchors are usually fenestrated nowadays, which allows for bone marrow exudate. But nowadays we prefer all suture type of anchors, and these are usually about 3.2 millimeters with double-loaded tape sutures, and these are ideal for rotator cuff repairs. The lateral anchors are knotless fixations, and these could be any form of screw-in or punch-in anchors. Anchors also, as a rule for large cuff tears, you need at least 1 or 2 anchors per tendon that's torn, so therefore you need 2 for the supraspinatus and possibly more for the infraspinatus or subscap. The medial row anchor is inserted right at the edge of the medial footprint, and large tears require 2 or more medial row anchors. Passing sutures would then be done 2 millimeters from the musculotendinous junction, either prograde by using a scorpion type of device, or retrograde using an arthro-pierce type of device. What about single or double row repairs? Double row repair has shown in this meta-analysis done in 2019 that they had better footprint compression, reduced gap formation, and better healing rates in tears greater than 3 centimeters. It didn't matter with tears smaller than 3 centimeters. So therefore, we prefer double row repair. The traditional double row repair is seen on the screen on the left, but the transosseous equivalent means attaching the medial to the lateral row, and this causes a compression of the footprint site. So in these, you can see a suture bridge type of fixation or a speed bridge with using tape sutures, and these allow for good compression and mechanical stability from time of surgery. What do we need to do about the cuff? We need to assess the reducibility. In this case, you can, on the left is a L-shaped tear, and this initially, when you pull the cuff, you'll be able to assess exactly its location and where it should sit, and this will give you the shape of the tear. And this is important to understand. This is also an L-shaped tear here, but pulling in all directions gives you that this is probably more a crescent type of tear. So we also need to identify this tear patterns. Colleen has classified these massive tears into those either anterosuperior tears involving supraspinatus and subscap, or a combination of global tears involving the posterior superior as well as the anterior superior cuff, and of course, those involving mainly the external rotators. The type A tear is like this, where we have a supraspinatus tear and an upper subscap tear. Type C is a complete tear of the anterior superior part. You can see upper 2/3 subscap tear, as well as a large supraspinatus tear extending into the infraspinatus. So this is important to identify, to understand the pattern of the tear and what tendons are involved. We also need to look at the shape of the tear. This is a crescent type of tear you're seeing right here. And these are easily on the screen on the right. You'll see that these tears can be brought to its insertion point and repaired using a speed bridge, a speed fix, suture bridge technique, both for the subscapularis as well as the posterior superior cuff. L-shaped tears, in this case, using a posterior superior tear, and these usually mean there's an L shape and a split between the tendons, and that will require margin convergence, usually to restore the tear between the tendons. The lateral row can then be performed in a normal speed bridge fixation. I usually use the sutures in the ankles to create margin convergence in these kind of tears. A U-shaped tear.
Lost your screen. Can we just
sorry.
share your screen again?
One sec. Are we good?
Not yet. Just keep going. Yeah,
Okay.
coming back.
So U-shaped tears, basically, if you see the screen on the right, you'll find that this is a U-shaped tear that has a split in the middle, and you can see the central part does not come through, but the posterior part can be drawn across it. These are best managed with a margin convergence suture. You see down here on the screen, the margin convergence has brought the tear together, and all we need to do is apply a separate anchor to the lateral fibers. Massive retracted tears, however, are retracted and generally irreducible. And you can see here, there's a spring back of the tendon as you pull it across. And these are different, as now these will require a release to mobilize the torn part of the tendon and then try to create some margin convergence and a lateral row repair. And this margin convergence is done in multiple sutures. To try and improve retraction, you'll need to do a superior capsule release to mobilize the cuff, this being the cuff on the top, and the capsule release performed with a radio frequency device or a spreader. You also need to release the rotator interval. In this case, this is released off the coracoid from intra-articular. And once this is performed, we will then do an anterior interval release. And following this, you'll find mobility is improved, where we can now bring the tendon back towards its footprint. Anterior slide gains about 1.5 centimeters lengthening, but posterior slide does not improve results, and therefore this is not performed routinely. If you cannot get the tendon back to its lateral margin of the footprint, you might need to consider medialization. This can be done 5 to 7 meters from the medial footprint. If you use a single row fixation medially, I usually prefer a triple loaded anchor with various types of suture configurations, and these have improved the pull-out strength, pull-out from the tendons. You must achieve a tension-free repair in the end, whichever technique you use. What about partial repair? This has been described by Steve Burkhardt using a suspension bridge technique, and he described that if you repair the subscap and infraspinatus, this will restore the horizontal force couples and improve function in the patient. We know that the rotator cable mimics the femur footprint, so therefore this may explain the reason why good function occurs from partial repair. So in this case, you'll see that we cannot repair the supraspinatus, but the infraspinatus was repaired partially, and long-term results have shown that these improve function. What about dog ears? With chronic tear, you will see dog ear formation from stretching of the tendon, and therefore does not allow for proper seating of the cuff. In this case, we normally would use a cinch loop applied to the dog ear, and this then brings the cuff down fully. And you see on these slides as well, cinch loops applied, accessory cinch loop applied to the repair site. Remember the biceps, this must be fixed. In this case, you see the bicep is fixed with the speed fixation over the biceps. And these must be done, biceps must be, tenodesis must be done for anterosuperior cuff tears or subscapularis tears. What about augmentation of the repair? Sometimes you see area defects or tendon degeneration, and these will benefit from using either a local graft, which is a vascularized graft, if the biceps is available. Other types of augmentation with synthetic allografts and xenografts have been used, but without success of the bicep tendon. This has been shown by a study by Shafi, where the biceps was inserted into the defect after margin convergence of these of the cuff. The biceps is inserted into the defect. If you're not sure whether you can repair the tendon, I would suggest doing an arthroscopic assessment. And at that time, if it's irreparable, you have an option to convert by having a superior capsule reconstruction available. The cost of these repairs, however, are large, and you can see multiple anchors being used. However, we know that massive cuff tears can progress to arthropathy, and repair should therefore be attempted to prevent this, especially in young patients. Not all massive tears are irreparable, and pseudoparalysis can improve. But however, fatty infiltration may progress, but muscle atrophy can be halted after repair. Therefore, this should be repaired in a young active patient, and in a young active patient requiring strength and mobility, consider releases, margin convergence, mobilization, medial repair, or partial repair and augmentation before considering non-anatomical reconstructions. In elderly, low-demand patients with poor compliance, poor biology, late presentation of cuffs, chronic pseudoparalysis, and advanced changes with cuff tear arthropathy, these are contraindications for repair of the rotator cuff. So thank you for your attention.
Thank you, Sham. That was an excellent presentation. I'm going to ask you to stop sharing your screen. And once you've done that, I'm going to ask Dr. Stadler Kirsten, immediate past president of the Shoulder and Elbow Society and prominent shoulder surgeon in Cape Town, South Africa, to address his topic, important principles of an arthroscopic acromioplasty. Stadler, please go ahead and share your screen.
Okay. Is that visible? All right, can you see my screen?
Yes.
Yes,
Thank
we
you.
can, Stanley. Thank you.
Okay. Thank you very much for the opportunity to the Egyptian Shoulder and Shoulders Surgery Association and South African Shoulder and Elbow Surgeons to present my talk on the important principles of arthroscopic acromioplasty. The procedure evolved since 1943 when Smith-Peterson described the lateral acromionectomy, followed by the complete acromionectomy by Armstrong in 1949. Anterior acromioplasty, which was a bit more conservative, in 1972, and then came Kaspari with the arthroscopic acromioplasty in 1992, and Gerber described the lateral acromioplasty based on the critical shoulder elbow in 2006. Here's impingement syndrome description. I'm going to refer to this as a guideline. Where stage 1 impingement is inflammation, edema, and hemorrhage with increased blood flow in the cuff. Stage 2, tendinitis and fibrosis, and stage 3, where the tendons are disrupted and osteophytes.
Stanley, your slides are not advancing.
Still advancing.
It's not advancing.
Yeah, go to PowerPoint page.
Let me just.
You're now showing us the acromion shape, Bigliani, 1986.
That's correct. Okay. No, I'm enlarging it now. Is that okay? So I'm going to continue with this. Bigliani, in 1986, he described the different types of acromion, and after that, there was significant debate about whether this is congenital or acquired changes. So eventually consensus was reached that the spur formation was acquired, but Shah in 2002 also had a good histological study that showed even type 2 and type 3 developed from the coracoacromial ligament traction. Is my slides advancing now?
No, just go on manually to your next slide.
I just want to see why it's not advancing.
It's advancing now, yes.
Okay. All right. So Takahashi in 1996 elaborated on the spur in the subclinical as well as the clinical impingement scenario, showing enlargement. The bursa's involvement in impingement was described by Burnett in 1996, with calcific tendinosis showing minimal bursal involvement, stage 1 and 2 impingement, hyperemic reaction of the bursa, and rotator cuff tears. There is localized fibrovascular reaction with marked increased type 3 collagen production. Gerber described the critical shoulder angle in 2006 and indicated that an increased critical shoulder angle at a higher incidence of rotator cuff disease. And he also postulated that decreasing the critical shoulder angle during surgery with the lateral acromioplasty can improve your outcome of rotator cuff repairs. So impingement develops by deltoid shear forces causing superior migration of the head, failure of a rotator cuff head, depressor function, and then secondary to that, impingement follows. Acromioplasty's role is to reduce the pain inhibition of the rotator cuff initial phase of elevation by limiting acromial contact. And that can be seen by the dramatic effect of pain inhibition after you've done the lignocaine infiltration test, which usually restores the ability for that hour after infiltration to elevate the arm. And I've seen in my practice more than once the improvement of thoracoscapulohumeral dyskinesis from subacromial pain, which is restored after the injection. So with acromioplasty, we want to restore the physical pull of the rotator cuff, especially the supraspinatus, to increase the concavity compression of the glenohumeral joint and re-establish a lower center of rotation of the humerus to maintain the subacromial space. Does this work? Well, there's conflicting results in the literature. Some studies say it does. Some studies say physiotherapy works just as good as acromioplasty. Others say you can just do a vasectomy, it will work just as well. but I've seen some studies where the refractory cases eventually underwent acromioplasty. So the effect of acromioplasty on the Oxford score is also interesting, that patients with a lower preoperative Oxford shoulder score get a higher rise in the Oxford score after the procedure. So that implies that worse cases get greater benefit from the procedure. Johnson also showed that there is a great increase in blood flow in the supraspinatus tendon after acromioplasty was performed successfully, whereas only a modest increase in blood flow among persistent pain after acromioplasty. So this suggests that impingement pain is related to impaired blood flow in the rotator cuff. In the stage 3 or rotator cuff tear stage, clinical improvement with acromioplasty and debridement only was shown by Yanaga in 1996, with the smaller, well, the A, B, and C, the smaller type C tears as described by Snyder. But on the other hand, again, there was other authors that showed there's no difference in outcome when a rotator cuff repair was done without acromioplasty, except for McDonald that said there's a higher reoperation rate in the non-acromioplasty patients. What about development of rotator cuff tears after acromioplasty? The primary tears usually developed, well, in 16% of cases, whereas recurrent tears can develop in 5.6% with rotator of acromioplasty and rotator cuff repair, or 9.1% when there was rotator cuff repair only. So this is due to disease progression and does not necessarily imply an unsuccessful acromioplasty. So should we abandon an 80-year-old procedure? We've all seen patients coming back at 3 weeks after their acromioplasty, and they're better than they've been in months, sometimes years. There's another question, is can you deny a patient surgery because of some papers dismissing the value of acromioplasty? I just think of one case that I know, a 34-year-old sales rep with a greater tuberosity fracture with minimal displacement, who was treated with medication and rehabilitation for 2 years. He couldn't play squash, he was limited in abduction, and with his scalp, superficial fraying and bursitis was found, and acromioplasty was done, and he was back at squash 7 weeks later with improved range of motion. Acromioplasty should be seen in association with rehabilitation. With rehab, we aim at restoration of the rotator cuff function and redevelop the force couples, keeping the head down. Acromioplasty addresses the consequence of rotator cuff dysfunction and facilitates a more effective rehabilitation. Acromioplasty in calcific tendonitis has also got some contention. Malay was postulated in 1995 that you can do a scope removal without acromioplasty and you won't see a difference if you did an acromioplasty, whereas Saragalia and Benzoquin showed the opposite and said you can do an acromioplasty without calcium removal, provided you created type 1 Bigliani acromion. So I do not always do acromioplasty for calcific tendonitis, but I do it if I see a clear impingement signs when in the subacromial space, or when there is granular calcium that cannot be removed. Growth factors have been shown to improve tendon healing when the tuberosity fenestration is done. There's animal studies and clinical studies that have showed better tendon healing in these cases. It has been shown by Rendelli that after acromioplasty, there's a significant rise in growth factors in the subacromial space. So my indication for acromioplasty is failure to restore the self-protective function of the rotator cuff after 3 to 6 months of conservative management, irrespective of the stage of impingement. But obviously, it is more common to do an acromioplasty in the setting of significant rotator cuff failure of stage 2 or 3 impingement. So I view from posterior, work from lateral, remove the bursa and release the coracoacromial ligament. Then I switch the scope to lateral and I appreciate the curve of the acromion. And then I go ahead and use the posterior acromion as a cutting block and create a type 1 acromion to make this a reproducible procedure. In the thin acromions, I would take less away from the acromion tip and not necessarily achieve to create a type 1 acromion. And in the irreparable cuffs, I would leave the coracoacromial ligament attached, only create a smooth undersurface of the acromion and remove prominent osteophytes. So when not to do an acromioplasty. The coracoacromial arch is the shoulder's secondary restraint system against anterosuperior escape. So with the irreparable or partially repairable cuffs, this is a salvage situation, and one should be careful not to disrupt the coracoacromial arch. I would also not do an acromioplasty if there's been a previous acromioplasty done and a type 1 is created, because then this is obviously progression of cuff disease, and one should address that rather. And then sometimes when the patient has a type 1 acromion, look for a prominent coracoacromial arch reflection on the undersurface of the acromion, or bursal hypertrophy, or both, and just remove that. So acromioplasty addresses the consequences of rotator cuff failure. It is aimed to improve shoulder biomechanics and to create space to prevent contact and pain inhibition of the rotator cuff. And it facilitates re-establishment of the lower center of rotation away from the acromion by rotator cuff head depressive function. Thank you.
Thank you, Stadler. That was an excellent presentation, and we sure will generate many questions. I'm going to now ask the third speaker to present. That's Nitesh Bhagwan. He's a senior shoulder surgeon in South Africa. He practices in Pietermaritzburg, in the city of Pietermaritzburg, and his topic is the superior capsular reconstruction, a viable choice in irreparable rotator cuff tears. Nitesh, please go ahead and share your screen.
Leon?
I can hear you, Nitesh, yes?
Can you see my screen?
Not yet. Please share your screen.
I am sharing it. It says that the host is stopping me from sharing.
Can I just speak to the organizers? Can they allow Dr. Bhagwan to share his screen, please? Conference organizers, can you allow Dr. Bhagwan to share his screen, please?
And he can perfectly share his screen. It's turned on.
And try again, Nitesh.
I'm not winning yet, Leon. I'm not sure if you want to rather move on with somebody else's talk.
All right, the next. Okay, so while Dr. Bhagwan is sorting himself out, I'm going to go ahead and share my screen. Can I confirm that you can see my screen?
Yes.
Okay, I'm going to go ahead and present this, and then we'll go back to Dr. Bhagwan. So the topic for me to consider tonight is the rotator cuff tears in the young patient. And for the purpose, in the literature, defines the young patient when we're considering rotator cuff tears as an individual less than 40 years old. And for the purpose of this presentation, I'm going to consider this in two groups: the young adult, 20 to 40 years, and the pediatric group 8 to 18 years. Now we know that the prevalence and risk factors for a rotator cuff tear in the general population increases with age. And we can see from this study that the incidence is very low below the age of 30 years, below the age of 40 years. So the first observation is that this is an uncommon presentation. Rotator cuff tears in the young are different from the elderly, and the differences relate to four aspects really. There's a difference with healing potential, a difference with tear etiology, a difference with level of activity and physical demand of the patient, and a difference in the long-term expectation of the patient. Now, this study in the Journal of Shoulder and Elbow Surgery in 2015 looked at a study population of 336 patients in the age group 26 to 40 years. And the first finding, which is consistent in this in this category of patients, is a male preponderance of 92%. The commonest tendon involved is the supraspinatus tendon. And the patients fell into two distinct groups. There were the non-thrower and non-overhead athlete who presented following a traumatic event with a full thickness tear, and the thrower or overhead athlete who presented with partial thickness tears as a consequence of overuse. In this age group, the outcome following surgery is consistently good. They achieve decreased pain and improved function. 87% are satisfied with the outcome after surgery, and arthroscopic surgery reports a faster recovery time. Return to play levels are consistently high, especially in the non-throwers. On the other hand, all studies have reported an inability to return to pre-injury level of competition in the thrower and overhead athlete. So the elite throwers represent a specific subset of patients in this age group. They present with partial thickness tears as due to a chronic overuse, and the majority demonstrate an inability to return to an elite level of play. What was striking in this review is a notable absence in the literature of studies that evaluate outcomes of non-operative treatment in young patients. And perhaps this is an area of future research. So the take-home message from this particular review is that most tears are of traumatic origin in patients less than 40 years. In this group, the rotator cuff tears respond well to repair. Surgical outcome is associated with high levels of satisfaction and return to play. There is, however, a subset of elite throwers who have partial rotator cuff tears secondary to overuse injury and difficulty returning to pre-injury level of play. The second article I'm looking at is I've used for the purpose of this presentation is in the American Journal of Sports Medicine from 2018, and looked at an adolescent, younger population between the age of 13 and 18 years. And again, 88% were male. In this group, 91% of the patients, the onset of pain was associated with a specific traumatic episode. The trauma occurred in most of these patients. It was an American study, playing American football, but the actual activities, there was a wide variation in the activities from baseball to bull riding, which probably says something about Alabama. 55% of the patients presented with following a specific instability event, either dislocation or a subluxation. And the consistent symptom in all patients is shoulder pain. The other symptoms vary from pain during throwing, subjective weakness, pain with overhead activities, instability, and numbness. The tendon involved was supraspinatus most commonly, but also subscapularis. In the supraspinatus tear pattern, the majority had partial rotator cuff tendon tears involving more than 50% of the footprint. However, in the subscapularis tear pattern. The commonest presentation was a tear associated with a bony avulsion of the lesser tuberosity, quite different tears. 40% of the patients in this study had an associated labral repair. And a concurrent labral tear is a risk factor for these patients. 43% of patients who had a labral repair rated sport performance after surgery as the same or better, whereas 78% of patients who did not undergo labral repair rated sport performance as the same or better. The time from surgery to follow-up was on average 6.2 years, and the return to sport at the same level was at a very high rate of 93%. Closer inspection, however, of subjective performance after surgery showed that 26%, or 1 in 4, reported that their sport performance after surgery was a little or a lot worse. The paper described a specific rehabilitation program, and of note, sport-specific exercise began at 5 to 6 months following surgery. So the recovery period for these young patients is over many months. More recently, in April 2022, in Arthroscopy, Sport Medicine and Rehabilitation, they published a systematic review of rotator cuff repair in the pediatric population. And in this group, patients were aged from 8 to 17 years, and 68% of 78 patients had an all arthroscopic repair. And the main messages from this review were that rotator cuff tears in the pediatric patient occur infrequently. Male collision sport athletes are most commonly affected. Supraspinatus was the most affected tendon, as similar as in the Alabama study. Early utilization of MRI should be considered when the clinical presentation is concerning for rotator cuff involvement. X-rays are almost always normal. Following surgical intervention, 90% are able to return to sport within 2.5 to 12 months. This was a shorter period than this. Some of these patients had a shorter period to return to sport than the previous study. But most of these studies did not report on the level of return to play. The explanation for the excellent return to play and low complication rates were considered to reflect a favorable biological environment and ability to heal in the young patient. Outcomes were excellent where the surgery was performed within 1 month of injury or delayed by up to 2 years in this pediatric age group. And this is in contradiction of the classic approach that early operative intervention is important for traumatic tears to avoid atrophy and scar tissue formation. In the pediatric patient with a late presentation still warrants repair. The caveat of this review was that the current literature investing rotator cuff injuries in the pediatric population is limited and of poor quality. So the take-home points. Rotator cuff tears in young patients is an uncommon presentation. It should be considered a different disease to that in the elderly. Most tears are of traumatic origin. Supraspinatus is the commonest tendon involved. Surgery consistently improves pain and function. Elite throwers are commonly unable to return to their pre-injury level of sport. Thank you for listening, and I'd like to take this opportunity to invite all listening to consider attending our annual meeting in the beautiful city of Cape Town in September this year. With that, I'm going to stop sharing. Nitesh, would you like to try to share again? Thank you, Nitesh. We can see your screen. Please proceed.
Hi, Leon, can you see that?
Yes, we can see it well and can hear you well. Please proceed.
So is the superior capsule reconstruction a viable choice in an irreparable supraspinatus tear? And I thank you for allowing me to be a part of this initiative. By way of introduction, I will cover the anatomy, graft options, surgical considerations, radiology, and clinical considerations. The superior ligament capsule is a static stabilizer that prevents superior translation of the humeral head, and this is dynamically reinforced by the rotator cuff. Any defect in the superior capsule leads to an increase in glenohumeral translation in all directions. Loss of the superior stabilization results in humeral head malposition and a dysfunctional muscular fulcrum that may ultimately lead to pain. Mihata in 2013 demonstrated that if we were able to restrain the superior translation of the humerus by restructuring the superior capsule, we could improve the biomechanics of the shoulder joint. The superior capsule is the deepest layer of the rotator cuff. It's a thin, continuous sheet of collagen fibrils, and this runs from the superior glenoid labrum medially to the humerus laterally. It was initially thought to be quite thin, but it's discovered to be almost 9 millimeters in thickness, especially in the posterior section. There's a well-defined posterior limb as well as a well-defined anterior limb. The suspension sling formed by the superior ligament, it functions almost in the same way that the inferior glenohumeral ligament functions. And the transverse band of the superior ligament is thought to represent Burkhart's rotator cable. When we look at the superior capsule reconstruction, it's thought to decrease superior humeral head migration and restores the normal glenohumeral joint position, just as the superior capsule does in the live shoulder. It's also now been determined that by increasing or playing with the thickness of the graft, we have a significant spacer effect. Mihata originally used a fascia lata autograft to reconstruct the superior capsule. However, this graft is thin and it often requires doubling or tripling of the construct. And there's also a significant donor side morbidity when we need to harvest the fascia lata. Allografts were proposed for the theoretical advantages, including reducing the donor side morbidity, shorter operative times, ease of preparation, and strength of the graft. In Mihata's original surgery, often 2 operating teams were needed, one to prepare the shoulder and a second team to harvest the fascia lata. We spoiled for choice, and there's many products that are available in the market, and these can be human dermal skin or they can even be porcine skin. I think it's very important to mention the biceps long head tendon as an autograft because of the costs that are associated with the dermal allografts. It's biomechanic equivalent and potentially stronger than a fascia lata autograft. If you're able to reconstruct the superior capsule with a long head of biceps tendon, it's able to require almost 4 times the force needed to involve superior migration as opposed to using a fascia lata graft. And multiple studies show that you're able to reduce contact pressure and improve the rotational range of motion. There's several patterns that we have available. You can do a simple transfer of the tendon to the middle of the tuberosity. If you are able to harvest a long section, you can create 2 points of attachment on the tuberosity and take the tendon back to the glenoid. You can make a zigzag formation. And the last final picture to the right even shows augmentation of a repair with the biceps autograft. It's something Shamim Osman showed in one of his pictures. The surgical technique in terms of the indications, the ideal candidates are younger patients, younger than 65. They are low-grade Hamada arthritis patients. There's advanced muscle atrophy, and the subscapularis is either intact or repairable. The relative contraindications are high grade of Hamada patients and older patients. Absolute contraindications are high grade Hamada patients or patients who lack active external rotation at the side, suggesting that the infraspinatus and teres major are torn or irreparable. The technique now has become fairly standardized, and the most commonly performed technique using a dermal allograft recommends 2 to 3 biocomposite anchors on the glenoid side. The medial row is then fixed either using a suture bridge, or it can be fixed using a single medial row fixation. A double pulley row technique is used to pass the graft into the shoulder. A speed bridge technique is then can be used for the lateral side of the graft fixation. And then anterior and posterior margin convergence stitches are used to secure the graft to the infraspinatus and or subscapularis. If there's any remnants of the original rotator cuff, then this can be used to augment the superior capsule reconstruction. So in these videos, you are able to see that there's a clearly missing supraspinatus. The subscapularis is visible. The infraspinatus is visible. There's remnants of previous surgery. The supraglenoid tubercle is then prepared and cleared of any fibrous tissue to create a fresh bony surface. 2 to 3 medial row anchors are placed. The tuberosity is freshened, and the speed bridge anchors are inserted. There's several devices available now to measure the size of the graft. Once these dimensions are available, the graft is prepared on the outside. Initially, the thinner grafts were used because they are much easier to pass into the shoulder. But if we now want to get greater value from the space effect of the superior capsule reconstruction, these grafts are then doubled up to try and create a thickness of about 4 millimeters. The initial technique suggested putting all the anchors in and passing them through the graft, but that really created a real spaghetti. I think to better improve your suture management, the graft can be passed into the shoulder just using the medial row anchors. The lateral row fixation can be done as a secondary section. So these pictures show this speed bridge technique for the lateral row, sutures between the infraspinatus and the posterior part of the graft. And when one looks from the glenohumeral side, you see the graft running nicely across from the glenoid to the greater tuberosity. Some of the surgical considerations that are quite important and also just shows that this technique is still evolving. And acromioplasty is important to reduce the risk of abrasive wear and tearing of the graft. A more recent technique suggests that if there's any graft left over, this can be used to cover the undersurface of the acromion, increasing the thickness of the graft and also augmenting the function of the graft as a spacer. When we use fascia lata as our reconstruction graft, Side-to-side suturing of the graft is recommended only to the posterior cuff. If you anchor this anteriorly, you will reduce your shoulder range of movement. This is different when you use a dermal allograft, as the range of motion is not reduced by anterior anchoring. And with dermal grafts, you should suture the graft to both the infraspinatus and subscapularis. I think it's quite important to look at MRI follow-ups of patients who've had superior reconstructions. If one looks at the two pictures, these are actually MRIs of patients who've had superior reconstructions, and they show that the ligament is very well visible on MRI scans. When we look at the failures, there's 5 modalities of failure. The suture to the infraspinatus can fail. You can have mid-substance tears of the graft. The commonest failure is at the glenoid attachment, and then the second commonest failure is at the greater tuberosity attachment. Complex tears can happen where there are 2 or more sites of graft failure. Because it shows that in patients who have intact grafts, they will obviously do well. But when you have graft failure, the site of the failure is important. If the graft tears at the glenoid but not the tuberosity, patients still tend to do well because you're getting the effect of the spacer effect of the graft. And this has been shown in several studies. Some of the clinical considerations, there are more and more meta-analysis that are available, and across a range of papers, you are able to see that the ASES as well as the VAS scores improve when this surgery is done with success. What's also important to appreciate is that your mean elevation and external rotation increases as well. But I'd like to highlight in these papers the pre-operative elevation. None of these patients actually had true pseudo-paralysis. They had good forward flexion and they had an improvement in the forward flexion. And the reason I emphasize this point is coming back to indications where we need to be careful about doing this procedure in patients who have true pseudo-paralysis. So in all analyzed studies, there were improvements in abduction, forward flexion, and external rotation. And with this improved function, there were improvements in pain, irrespective of the different types of graft used. There were, however, complications and reoperations and graft failures. I'd like to end showing 2 cases with patients who had very similar demographics. On the left, a 57-year-old male plumber who fell 18 months ago. He's had 2 previous attempts at rotator cuff repairs. You can see the subscapularis and infraspinatus are both intact. On the right side, a 50-year-old male patient who owns a businessman who hurt himself in the gym, also had 2 previous rotator cuff repairs. Subscapularis is intact. There's remnants of the suture material in the infraspinatus, but generally an absent or irreparable supraspinatus. MRIs show humeral head migration and no evidence of any supraspinatus tendon on the preoperative limbs. But the clinical appearances were significantly different. Patient on the right had pseudo-paralysis, and he underwent a latissimus dorsi transfer through a mini-open approach. The patient on the right was able to maintain forward flexion, and he underwent a superior capsule reconstruction. So in summary, these are 4 possible options for younger patients who have irreparable supraspinatus tears. Physical therapy it doesn't hurt to try it. In patients who have pre-existing arthritis or pseudo-paralytic, rotator reverse shoulder replacement is an option. Tendon transfers and superior capsule reconstruction both have similar shoulder subjective values, but a tendon transfer is probably a better consideration in a patient who has pseudoparalysis or multiple lag signs. The demand on the superior capsule reconstruction is far greater than that of the original capsule, as in the original as in the untorn rotator cuff, the supraspinatus tendon is there to augment the capsule. However, there are biomechanical and clinical studies now suggesting that the superior capsule reconstruction does translate into improved clinical outcomes, but we still have questions regarding long-term outcomes, graft healing, then why these patients improve in the short term, and then questions around the ideal graft and the thickness. So I thank you for your attention.
Thank you, Nitesh. That was an excellent presentation, and I'm sure there'll be many questions again. I'm going to ask Professor Basim Vlieger to do the next presentation on cuff tears in high performance athletes. Basim. We can see your slides, Basim. Go ahead.
Thank you. Okay. Thank you very much, Leon. It's my pleasure having you with us as South African shoulder surgeons to join our Egyptian Shoulder Association in presenting these nice webinars, and as a beginning of a long-lasting cooperation for the welfare of all the surgeons in our area. First, I will talk about rotator cuff repair or rotator cuff tears in high-performance athletes. If we go to the literature, we see that overuse is a main cause of rotator cuff tear in athletes, especially in patients over 40 with overhead sports as handball, tennis, basketball, golf, and swimming. Also, trauma and collision are typically attributed to falls or collision sports. In 1972, Neer has presented his paper on impingement syndrome and classified it into 3 stages, as my colleagues also said before. And the third stage is the one with rotator cuff tear. He named it as outlet impingement, which is a narrowing of the subacromial space, either due to the shape of the acromion or with spurs formation in the anterior acromion, which was also nicely described before. 95% of all rotator cuff tears were due to outlet impingement, as he presented, and the age was above 40 years of age with an average of 58 years. We did our arthroscopic classification of the subacromial space, and we measured the distance between the anterior acromion and the cuff and classified it into 4 types, in which type 0, there's the space more than 12 millimeter, and then type 1, 2, and 3, which is there's no space at all between the anterior acromion and the cuff. So our subacromial decompression is guided by this to get our target having a space of more than 12 millimeter, using a special measuring needle to measure the space between the anterior acromion and the cuff. In the literature, partial thickness tear is treated mainly with arthroscopic debridement, which brings fairly good results, while full thickness tear is not as good, especially in overhead athletes, and the outcome after surgery is also not very promising. Partial tear, either joint side or bursal side, and also we see here there's a weakness of the tendon and ballooning of the supraspinatus tendon, which without really a tear, but we call it a spoon lesion. So we treat that as a partial tear and resect it and do a reefing to the supraspinatus tendon. Now, the most commonly used techniques in rotator cuff repair in the literature is the anchor technique, either single row or double row, and recently also the different variations of these techniques. Return to play. The literature conservative treatment of a period of rest and then physical therapy, followed by a gradual interval throwing program leading to a full sport participation. If this doesn't happen in 3 months, then surgical intervention will be advised, and surgery can have a post-operative rehabilitation period of between up to 6 to 12 months till the patient can go back to his sport. So in some, it is about 1.5 years that can let the athlete go back to his performance as before surgery, which is actually a very long time and a very bad thing for the athlete. Now, what about the arthroscopic rotator cuff repair in high performance athletes? We asked the following question: what is the etiology of a tear in high performance athletes? And does rotator cuff tear happens mostly in contact sports? What are the types of tear? Is subacromial decompression needed in these tears? Does a special rehabilitation program enhance return to sports? And what are the results of transosseous repair? To our knowledge, no study is present in the literature dealing with this subject. So what we did, we reviewed our cases of athletes who had injury of the shoulder between 2014 and 2020, and most of them were weightlifters, tennis players, handball, and water polo players, followed by swimmers, boxers, volleyball, and football players. Of course, we don't have a lot of rugby players like in South Africa, but also we had 5 patients. And the most common shoulder injury in these cases were impingement syndrome, shoulder dislocation, and glenohumeral subluxation, followed by rotator cuff tear and acromioclavicular joint dislocation. Out of these cases, we had high performance athletes who had the surgery. There were 35 cases or 14% of the all. There were 28 males and 7 females, and we choose only competition athletes who were on national and international activity. 14 of them were contact sports and 21 non-contact sports. Instability was present in 6 of these cases. There were mostly also weightlifters, volleyball players, boxers, handball players, water polo, football, and sprinters. 25 cases had acute trauma and 10 cases had micro trauma. 3 of them were also had an outlet impingement pathology. Mechanism of trauma is either a balancing trauma, especially in weightlifter, where they lose their balance and they got the shoulder injury, contact trauma, fall on outstretched hand, and micro trauma. The etiology of the tear in high performance athletes was contact sports in 40% of the cases, balancing and fall trauma in 31%, micro trauma in 20%, micro trauma associated with outlet impingement in 8%, and contrary to the all cases where 95% were due to outlet impingement. Subacromial narrowing, but the rest was present in 32% of the cases, as we measured it, which is less than 12 millimeter space. Now, the average age at surgery was 25.8 years compared to 58 years in the average population. 23 patients had partial tear and 6 small tears. So it's about 83% of the cases had partial to small tears, while only 6 cases were medium and large tears. All cases had an arthroscopic rotator cuff repair, 31 of them transosseous and 4 end-to-end repair. Why we use transosseous repair? Because it restores the footprint and may have a compact stability of the tendon on the barefoot area. For this is the technique we use for the transosseous repair. It's called the giant needle technique, and we pass the suture transosseally through the tendon and through the bone, and then we pull the sutures out and make our sliding knot to fix the tendon. So the question is, we do need to do decompression with these cases. As we have seen, 11 of them had a subacromial space of less than 12 millimeters. So we did a subacromial decompression only to these cases to get the space more than 12 millimeters. The rehabilitation, special patient custom-made rehabilitation program was done. The patient has to do his exercises 5 times a day at home, and 1 or 2 up to 3 times weekly go to the physiotherapist. Most of the patients followed this program, and the measurements which we did, we followed it on the group of muscles divided into 10 groups, and our target was to get this strength the same as the opposite normal side. Most of the patients returned to their competitive sport between 4 to 6 months after surgery. Now the post-operative performance and result: 1 boxer and 1 American football player didn't continue his competitive sports. All of the other patients went back to their competitive activity, and many of them even were able to get national and international championships. So, in summary, and the answer to our question, the etiology in high-performance athletes is outlet impingements is only in 8% of the cases. The rest is traumatic or microtraumatic. Rotator cuff tear happens mostly in contact sports in 40% of the cases. The type of tears, 83% are partial to small tears. Subacromial decompression is done only in cases where there is a narrowing of subacromial space, which is only in 28% of the cases. The special rehabilitation program was very effective to these patients, and the results of the performance of these patients was good, and 94% returned to their competitive sports activity. Finally, I want to also have the pleasure to invite you to our second annual meeting, which is in the same month like in South Africa, but at the end of the month in Cairo on the Nile and under our beautiful sun. So all of you are invited. Thank you very much.
Thank you, Basim. That was an excellent presentation with many insights that from South Africa, very interesting insights from South Africa. Some of us may have heard for the first time. I have lots of questions. The last, but the final talk for this evening is from Dr. Hani El Sayed. I'm going to ask you to stop sharing your screen, Basim, and Dr. El Sayed to please start sharing.
Okay. Dr. Basim, stop sharing. Thank you to all my seniors. Now it's last talk. It's the situation which we all don't want to see it on our patient is a failed rotator cuff. My acknowledgement to my seniors who learned me how to deal with this patient. My senior Professor Stephen Booker and DC and Sonati and Elio. So rotator cuff tear, it's a diseased tendon. It's not a healthy tendon. So we now fight against biology. So this is not a normal tendon to deal with it. The return rate on the literature from 2004 until now is average from 94 until 25. The best number is 25. And it have relation between the size of the tear and the return. And the return is now from 25, it's a big number. With this new revolution on the shoulder and the new surgeon on the shoulder, we need to minimize this number because a high number of complication for this surgery, 25. So now we need to know what is the problem which makes the tendon tear again. When we see patient on our clinic post-surgery with pain or stiffness, we have first to take a long breath. And after that, think, why this patient come? Pain or stiffness or weakness or what? And we need to be no panic, don't panic, and start to analyze what's happened to the patient. Post-operative pain and this stiffness means that there is something on the tendon. Is it a return or it's failure to heal? As we all know, that the failure start in the tendon suture interface. This is the area which start failures. So we need to know, did this patient need surgery again? And how we can make it better on the next surgery? And what we can do in the second time to avoid this return? How can I do that? I need to analyze. Start to take a good history, good previous surgery, what is done on the previous surgery, and revise the MRI previously. See any missed pathology as the common cause of return, the missed pathology, subscap, biceps, or AC joint. We need to search about infection. Don't forget infection or low-grade infection. So we need to evaluate the patient good. 2 tricks on the MRI, I found it in my life. This 2 patients. First patient is 45 years old, come with, after surgery 3 months. With this MRI, have this area, which means that the tendon is retracted. The patient pushed to the surgery and defined imagine intraoperatively, this is a subacromial, and this is subacromial, and this from the joint, found that a good repair. So we need, don't forget that the patient vascular state take 6 months to heal. So the patient on the first 6 months is on a vascular state. So we have to consider this. And the other issues is the high strength sutures. This is why we now use the low strain to avoid this appear on the MRI. This is another patient with this MRI shows that there is a gap between the tendon and the footprint. But imagine it was a high strength sutures. It's not a tear. So we have to consider MRI on the revision case after 6 months to 2 issues: high strain or high strength sutures, and the other issues, the vascular state. So the most common causes of retear is the biology and the technical factors. We are lucky if the problem was the technical factor, but we need to know what is the biology. Biology, age of the patient, old age, smokers, non-compliance to physiotherapy, size of the tear, it all affects the healing of the tendon. The new era now is talk about the muscle atrophy. This is a case, just do it. Imagine this is a proximal migration, tendon retracted until the glenoid, the gluteus type 3 is the tangent line, the muscles under the line, and here is the upper subscap. Imagine the patient have a repair, and this is MRI after 3 months. See how the patient, as Sham just mentioned on his nice literature, nice topics, that MRI post-repair for this gluteus type 3, imagine it's a supraspinatus gain its contouring and gain its strength post-operatively. So I found now that a lot of surgeons rely on the MRI that is gluteus type 4 or type 3, and you have to push the patient to do reverse shoulder arthroplasty, but he don't think about that is gluteus, I think, need to be mobilized again and rethinking about the gluteus, because a lot of cases now with gluteus type 3 even, and with the repair with some techniques on the release, it gain a strength on the muscle, and it gain a good repair, not a partial repair even, it's a good repair, double row suture bridge. It's very nice. So it need a little bit some modification on gluteus type 3 and type 4 on indication for reverse shoulder arthroplasty. As we see nowadays that gluteus type 3, you have to do reverse shoulder arthroplasty. Give the patient chance. See, this is MRI. This MRI immediately, 3 months post-operative, how the tendon is become good. Pseudoparalysis is an entity. If you face patient with pseudoparalysis and the repairable tendon, he will gain 90% to regain overhead activities without previous surgery. But if you have on a revision case, the patient come to your clinic after 8 months with pseudoparalysis, you have to be good about the prognosis of these cases, because pseudoparalysis post-surgery means that the prognosis will be have some good. So it's 40% only overhead with a good repair. Technical factor, as I mentioned before, you are lucky if you face patient with failed rotator cuff tears. The problem is from the previous surgery, because you will face some missed pathology or missed technique on fixation, or some tendon need to be readdressed again. So you are lucky if you face patient with failed rotator cuff repair, have previously surgeon experience low volume, so you are lucky. Tear pattern, you have to understand what is the tear pattern. Missed pathology, as I mentioned, surgical technique previously, and you have now 2 options. If it's arthroscopic or open. So what is our indication for repair? Is MRI is recent with decreased muscle atrophy or retraction, active range of motion. You have to have a good patient, our compliance with physiotherapy, and we deal with physiotherapy and fixed physiotherapy, and see the patient education about the physiotherapy, and discuss with him to see if he will be compliant with physiotherapy or no. So we have a fact from literatures that a healed rotator cuff have a better prognosis, even some cuff defect have a good satisfactory for the patient. See here, if you have some gaps on the repair or like a partial repair, have patient satisfaction. And on my hand, I see a lot of patients satisfied with partial repair better than reversed shoulder arthroplasty. So how we decide? As I mentioned, we have two options, open or arthroscopic. Open have a mixed result, but 67% on the massive tear. Arthroscopic, on our hand, we see as the result is better than is open because we have some missed pathology. You have to see inside the joint, you have to see the biceps tendon, you have to see the subscap from inside the joint and from outside the joint, inside view and outside view. I think all these issues you cannot reach by open. You need to be done by arthroscopic. As I mentioned, you are lucky if the problem with the surgery is operative stiffness or post-operative or surgeon. So you have now some missed pathology, you have to deal with it. On my hand, subscap, biceps, and mesial fixation is the most common cause of failed rotator cuff. Option, conservative, we don't neglect the conservative because if you have MRI and we have forced couple is intact, so you can rehab the patient and get a good result. Operative, irreparable, I think we have a lot of topics about irreversible, partial rotator cuff repair, subscapular, superior capsule reconstruction, and we just see these topics. Dermal allograft, latissimal dorsal transfer, or reverse shoulder arthroplasty. But my talk today about repairable tear. Before we embark to the repairable tear, I have make a strategy for myself, how I will start and what I can do if I feel some problem. As I mentioned, subscap, even myself on the start of my life, on my work, I have some missed subscap because we all make static arthroscopic examination for the subscap. And if we use lens 30 on the picture, you may miss upper subscap. As Lafosse mentioned, type 2 and type 3, you may miss upper subscap pathology on a static examination by arthroscopic. So I learn a lot to do dynamic examination for the subscap, like make flexion 30 degree, and the scope is 30 degrees, so it's now 60, and make some internal rotation and do posterior lever pull and see the subscap. Because myself, I see the comma as its subscap. So we need to investigate good subscap. On my hand, a lot of revision come from missed subscap pathology. So this is one case. If you see from the joint, it appear normal, but when you stretch on the biceps and see that the upper subscap is torn, and this is a comma, not a subscap, so you will know what's happened to the subscap. So you have to see the biceps, you have to identify the comma, and start biceps tenodesis, and I use the biceps tenodesis sutures to suture the subscap, upper subscap. As you see here, we have to investigate the biceps tendon. When the biceps leaves the bicipital groove, this means that we have a pathology on the subscap, and this is the comma which you all, sometimes we mistake it as a subscap. It's a comma, not a subscap. When we pull on the comma, we will see the subscap, and see always the biceps tendon is leaving the groove. So this is the first pathology on the revision, is examination of the subscap and the biceps, and if there is a pathology, I will inform to it. Second thing, a lot of adhesion, so I will use a lateral portal and use from posterior and make excavate or release between the soft tissues under the acromion and the rotator cuff, and see this plane good to excavate the space between the rotator cuff and the acromion. As you see here, and this is tissue which you mistake it as a rotator cuff. It's not a rotator cuff, it's bursal leaders. It leads us to the rotator cuff. So we have to investigate this bursal leader and go posterior with it between the deltoid and the rotator cuff to see this bursal leader. And don't mistake, this is not a cuff. And sometimes we think that's a delamination and make a repair for that. It will make a cost for us and a lot of time. So this is a bursal leader. As we see here, bursal leader. After that, I need to identify scapular spine to know where is the supraspinatus and infraspinatus. This is acromion, anterior acromion, and a lot of adhesion. And I go back to see this keel shape. This keel shape means that it's interval between the supraspinatus anterior to it and the infraspinatus posterior to it. And I now start to release under surface the acromial spine and release adhesion between supra and infraspinatus and acromial spine. And now I identify anterior, I will be supraspinatus, posterior, I will be infraspinatus, and this is the keel shape. As we see here, this is a keel shape between supraspinatus and infraspinatus. After that, I need to attack the sutures. I will remove the sutures from the previous repair. And after that, I will end with this situation. Cuff tear, biceps tendon, supraspinatus. So what I can do now, this is the tear. After removal of the suture, make debridement. I have a massive tear. So this is type of tear now is a massive. I need to plan what I can do now. If it can go, sometime after this removal, you can stretch on the tendon. You will find this tendon is movable with you. So you can make a direct repair. But if not movable, what I can do, I need to do interval release. So anterior interval and posterior interval. The key on the anterior interval is this ligament, coracohumeral ligament. Coracohumeral ligament gives 2 centimeter or 18 millimeter lateral release for the supraspinatus. So coracohumeral ligament is the key on the anterior interval release. I have to reach it and remove it to make some release for the supraspinatus. This is from anterior. As Sham mentioned, infraspinatus, most of time, it not need a lot of release because it can move with you. Most of massive tear or L-shaped tear on the supraspinatus and rotator interval with the subscap or biceps. But if you have some problem with the posterior interval or infraspinatus, as we mentioned before, the keel shape of the scapular spine, and put my knife until it sees fat. This is the identification for the nerve to make some suture on supraspinatus and infraspinatus and make marginal convergency and start repair. So now I make anterior release, posterior release, but I have also some shortage of the tendon. We come now for our Professor Dr. Buchert. He mentioned load sharing grab stop. Load sharing grab stop is very nice options, or it's called also cable reconstructions. We put fiber tape here on the lateral on the cable and make cable reconstruction to pull the tendon, and after that make the sutures. It gives us a lot of lateral release for the tendon. So rep stop or load sharing rep stop or cable reconstruction, or the same name, is also of the tendon not coming after all releases. As we see here, this is a cable reconstruction, and this is the sutures. Suture, now we make all release, tendon come with me. I need now to make medial row and lateral row. I change lastly to use soft anchors medial on the medial row and medialize it soft anchor. I found this soft anchor have a high tensile strength like the Swavelock anchor or the biocomposite anchor. It preserve bone, especially you have now a revision case, so I don't have a lot of bone to use. So I choose 2 strong bone area and both 2 soft anchors, or I use what's called expansion speed bridge sutures on the medial row, both soft anchor on the medial row, and use on the lateral row Swavelock anchors. So I now change my mind to use soft anchor on the medial row, and I have some belief that tying of the medial row is good because prevent synovial fluid come from the joint to the undersurface of the acromion. So I think this is synovial fluid come from the joint will affect the healing of the lateral row. So I now tie the medial row and put on the Swavelock on the lateral row. As I see here, I put soft anchors on the medial row and medialize it and use expansion bridge. I distribute the sutures on the tendon and tie medial suture, take on the lateral suture. As you see here, I put 2 medial anchors here and start to converge my suture on the rotator cuff and tie the medial row. As you see here, to end with this, I suture the medial row here and take on the lateral row. This is my technique on revision cases. I think it is a very nice technique and I have a high result. Last time we Yeah, on my hand, we will decrease rate of revision rate until 5 or 6 because it's not acceptable 25 degrees. So summary, we have to identify the causes and make a plan, and it will end with succeed, inshallah. Thank you.
Thank you very much. That was an excellent presentation. I'm going to begin just by trying to address, I'm going to keep it at about 5 minutes for each of the speakers. I'm going to start with Dr. Osman. One of the questions that came up was, is there a difference between speed bridge and suture bridge? Are you able to comment on that, Sham?
Yeah, well, the suture bridge is basically using fiber wire or one of the strong sutures. And speed bridge was developed by Arthrex, where they use fiber tape, which allowed a double fiber tape to be put onto the medial row and then passed crisscross onto the lateral row. But that was using fiber tape, which is tape sutures. And the difference was basically the technique is still a suture bridge, but in the speed bridge, this utilizes fiber tape in a crisscross fashion.
And does tape, as opposed to suture, offer an advantage?
Yes, it does. I mean, we've shown that this a Burkhardt study where he talks about the Hong Kong skyline using not the system, but using tape sutures. And tape sutures provided a better grip on the tendon compared to sutures. So less cutouts and more compression on the footprint due to tape construct.
Thank you. Thank you very much. I'm going to just skip a little bit because I think there's relevance in this. Basim, the question is really for you. The question that came up from the audience was, when would you choose to use a giant needle technique for a rotator cuff repair?
In general, also for all cases, not only athletics, I always use the transosseous repair technique for all my cases, actually. Even for large and massive rotator cuff tears. For me, it is a very quick technique, and I do all the steps in about 20% of the time needed if anchors are used. So I do it for all my cases. And I did more than 10,000 cases till now.
All right. Thank you, Basim. That's a phenomenal experience. May I ask, I'm going to co-moderate the session with my colleague, Stadler Kirsten. Stadler, do you have any questions?
Yeah, I'd like to ask Shamim about how does he approach the release of the rotator cuff if you see you can't get the cuff down to the footprint. What is his, just shortly, is the steps that you take, Shamim?
Yeah, sure. Well, there's two parts to it. Dr. Al-Sayed described it quite well. The two parts are basically, you need to release the superior capsule. That means putting a little suture on the supraspinatus, or even a suture grasper onto the supraspinatus, pulling it towards you. You then release the superior capsule. As Dr. Al-Sayed showed, that if you come close to the scapular spine, you need to be careful because that's where the suprascapular nerve is. So you wouldn't go beyond 2 centimeters from the edge of the glenoid. That's the first part. The second part is to release the supraspinatus from the coracoid, releasing the coracohumeral ligament, and also doing an anterior release between the supraspinatus and the subscapularis, which would be an anterior interval slide. So combining the capsular release with the interval slide anteriorly, you should gain at least 1 to 1.5 centimeters, and sometimes up to 2 centimeters of lateral mobility of the supraspinatus. So those are the two main steps. The posterior release or posterior interval slide is not shown to have significant improvement in functional outcomes. And therefore, if you can't achieve mobility to the medial row, especially the lateral footprint, you would consider medialization after an anterior release. So medialization of the cuff rather than trying to do a posterior release for those cases. I hope that answers.
Thank you.
Yes.
Yes, absolutely. Yeah, it's quite descriptive. Leon, and then I'd like to ask you, in terms of what did you find in the literature regarding in young patients the issue between single row repair and double row repair?
So that was not firstly, we have a paucity of data in that regard. The suggestion was that the double row repair would be the preferred technique, particularly in the young adult. And that would be because of the better footprint restoration of the footprint and better contact pressures. So I think that would that most people would favor transosseous equivalent technique using sutures, and I think that the suggestion, this is more an opinion than from literature, the all suture anchors probably give us better options in the younger patient. Basim, while we're on that, have you used the transosseous technique in the young patient?
Yes.
And have you had any difficulty with that, or has it been the same?
No, actually, I don't see any reason for the difficulty, except that young patient, the shoulder may be very small compared to adults, and in that case, we use a small needle for that. So there are different sizes. And small sizes are for young patients, and also some women who are very thin. They have also small shoulder. For these two groups, we use the small needle, which is about 5 centimeter. It's the smallest one.
Thank you. Dr. El Said, would you like to just comment a bit on mobilization of the rotator cuff, particularly your explanation of the bursal leaders?
Mobilization on some cases, also I have to add some releases for the capsule. Even with this proximal migrations, I found some inferior release of the inferior capsule make this proximal migration a little bit calm down, because we have a lot of constructed soft tissues on that area. And also, as Sham mentioned, we have to release superior capsule or especially coracohumeral ligament. It really inside intraoperative, it would have 2 centimeter pull out for the supraspinatus come out with you from the superior capsule and even with the inferior capsule. Some new techniques now regarding the inferior capsule have shown a superior result with decreased return rate, but it's not published until now, but it have a strong recommendation to make some inferior capsule release on that massive tear or a revision tear. Yes.
Thank you. Thank you very much. Stadler, there's been a question for you in the audience. How do you, with an acromioplasty, address an os acromiale?
Yes, yes, you can. The osteoacromiale at the tip is usually removed at the same time as an acromioplasty, whereas the I think it's a mesoacromion, which is in line with the posterior corner of the acromioclavicular joint. There is 2 schools. The one is says no, you have to fix it and not do an acromioplasty and attempt to tilt the anterior piece to the extent that you can increase the subacromial space. But there was also a Cape Town study that said this osteoacromiale with the in line with the posterior edge of the AC joint can be resected arthroscopically, specifically, maintaining the deltoid fascia and the periosteum of the superior acromion, and they had similar outcomes. So yes, personally, I favor the the fusion of the osteoacromiale. Yes, and then obviously the base of the osteoacromiale is treated differently.
Thank you. I'm going to just now ask Nitesh, when we're dealing with superior capsular reconstruction, at how critically do you assess osteoarthritis in these patients, and have you ever changed your mind intraoperatively to think that the osteoarthritis is too advanced for a capsular reconstruction?
I think, Leon, we really need to look at the age of the patient. I think you can't just look at the arthroscopic findings. I think if there's early or minor chondral damage, then, and the patient is physiologically young, then there's, it's very difficult to ascertain where the pain is coming from. Is it from failed biomechanics, or is it from the chondral damage? Often we've discussed the options for surgery prior to going in. And most of the time we're indicating superior capsule reconstruction in patients who seem to be quite adamant that they don't want any arthroplasty done. But I don't think it's an easy question to answer. I mean, if you follow the general guidelines, if they are low Hamada gradings, grade 1 or grade 2, then even with that little degree of chondral damage, you can still go ahead and do a superior capsule reconstruction. I mean, with the two cases that I presented, I don't think, either candidate, even with a little bit of chondral damage, would have been a reversal replacement would have been an option. I think if you have a failed tendon transfer, a failed superior capsule reconstruction, then that becomes an option. So, yeah, I think it's a difficult question to answer. I'm not sure if anybody else on the panel has experience with doing a superior capsule reconstruction when there's chondral damage. I know Steve Burkhardt has taken it one step further in terms of also resurfacing the glenoid with a dermal allograft in addition to doing a superior capsule reconstruction. But, that's a small, very few patients that may need that. And maybe there is a little bit of a bias in that patients when he's treating them, because he's primarily an arthroscopic surgeon and doesn't do arthroplasty. So he may really push the limit as to what he will do with these dermal allografts. Yeah,
Thank you.
I don't know if anybody else has a comment on that particular question.
While we're thinking about that, Dr. El Sayed, there's a question I think that people in the audience, do you use PRP in your revision rotator cuff repairs, either at the time of surgery or after?
We have a very nice published literature, systematic review and meta-analysis in 2020. Talk about these issues, especially on the bone tendon healing. They talk about PRP intraoperatively, arthroscopic. It enhances the healing of bone tendon healing and decrease the repair rate. So it's now a recommendation if we do bone tendon repair to inject PRP. The only issue is that you have to balance between the water and time of injection. You have to evacuate the shoulder a little bit and put a stable needle inside and try to inject. It's a very nice paper in 2020. Talk about this PRP. Yes, yes, we recommend.
Thank you. Basi, maybe you could answer this. There was a question as when would you begin active range of movement after a rotator cuff repair? What is your approach?
Actually, it depends on the size of the tear and the stability of the reconstruction. So if it is a small tear or medium-sized tear, and there is no tension on the rotator cuff reconstruction, having the arm in complete adduction, these cases, they start exercises immediately the second day after surgery with pendulum and then pulley. I mean, passive assisted exercises for 4 to 6 weeks. I allow them to use their hand for eating, drinking, and doing everything without elevating the elbow. Tell them, keep the elbow down and do what you can. And even now, we let them wear the sling only outside home or office, but inside home and office, they can not use the sling, but they have to be aware that they don't elevate the elbow. In cases where the reconstruction is tense, I mean, in general, I don't do a reconstruction if I cannot get the tendon to the barefoot area in maximum 30 degrees abduction. So in these cases, they have a sling with an abduction pillow or brace, and they start only from the brace, the passive motion with pulley exercises, assisted passive, but they have to wear the brace the whole 6 weeks. And they are not allowed to use the arm at all, except the hand. They can use the hand for writing and so, but they have always to keep the elbow on this pillow. But all parts after 4 to 6 weeks, then they start assisted active elevation.
Thank you. Sham, would you just like to comment on rehab briefly before I give Nitesh the last question?
Yes, I kind of agree with Dr. Bassam that the smaller chairs, medium-sized chairs with good on-table construct that I see, I would be quite free and allow them activities quite soon. They would probably need a sling support. It's actually not even immobilizing, but the sling is to remind them not to use their arm or to prevent any sudden injuries that may occur. With the bigger chairs and revision rotator cuff repairs, I'm talking about big chairs, massive chairs, 2 tendon, 3 tendon chairs, or in revision cuff repairs, I'm quite conservative. I would tell them 6 weeks of immobilization, and as Professor Friga said, just minimal activity with the hand, no leaning on the arm, no lifting the arm, and they would have passive mobilization, but supervised by a physiotherapist. After 6 weeks, they would start a formal rehab program. So smaller chairs, less time in the sling, more freedom, but larger chairs, revision chairs, I would tend to want to keep them immobilized for a longer period.
Just before we leave this topic, Dr. El Said, with your revision cases, are you more conservative or do you change your rehab as compared to primary repairs?
As I mentioned, I have concept a little bit on my life, make life easy. If we do MRI for the patient and see forced coupling is intact, subscap infraspinatus is on place, humeral head is centralized. So this problem, I think, was the rehabilitation. So rehab the patient and rehab the patient and rehab the patient and don't panic. So make life easy a little bit on the revision case. If the problem was the compliance with the physiotherapy, I think it have a little bit rules. So rehabilitation have a rules on the patient with intact force coupling.
Thank you. Nitesh, I'm going to give you the last question for what's been an excellent set of presentations and discussion. There's been a question on how do you judge tension on your superior capsular reconstruction graft?
Okay, so fixation angle, whether using allograft or whether using fascia lata, remain unanswered. The biomechanical studies suggest that the superior capsule reconstruction using an allograft should be tensioned between 30 to 60 degrees of arm abduction. That's for dermal allografts. Mihata suggests for using fascia lata autografts that you tension at 30 degrees. Yeah, I think, but there isn't any clear data on the exact abduction angle that which you need to tension your graft. I think it's also very important to get the sizing right. You certainly don't want a graft that's being cut too big and now is loose within the joint. So taking accurate measurements using the right device is quite critical. And then the other factor besides tension is thickness of the graft. Again, there isn't very clear information on what the appropriate thickness is. Biomechanically, the thickness of the graft for allograft should be between 4 to 5 millimeters thick. When using fascia lata grafts, they are almost 8 millimeters thick. And I think the idea for both of those is to now to try and galvanize the spacer effect that you get. So sorry, I answered a bit more than what you asked, but the general guidelines is 30 to 60 degrees of abduction when you tension the graft.
We've got to 9 o'clock, which is where we had expected to be. So I would like to take this opportunity to say thank you to all the presenters. From the South African Shoulder and Elbow Society, I especially want to thank the Egyptian Shoulder Society for coming up with this idea of joint webinars. It's been a very exciting time for us. The attendance has been impressive, both in terms of numbers and geography. We look forward to extending this program in the future. I'm going to communicate with Basim to facilitate as much contact as possible between us at our respective meetings. And I'm sure we can come up with ways that would be suitable for members in both societies in both countries. So thank you for all. Good night, and thank you for the participants who've stayed with us for these 2 hours. I think it's been well worth it. Excellent discussion, extremely high standard, and very experienced surgeons. Thank you very much.
Thank you.
Thank you.
Thank you.
Good evening, everyone.
Good evening.
Good night.
Everybody, thank you. Good night.